Hello and welcome back to another Med-Minded Monday. We have another video here breaking up the infectious diseases trend we've been on. Today we're on to the Class 1 Antiarrhythmics. I am Robert Lasko. I'm a clinical pharmacist in the emergency department at the Washington Hospital. I'm also the founder of Med-Minded Consulting, so let's just go ahead and get into it. So first, a brief overview. The Class 1 antiarrhythmics, they block the fast sodium channels and it reduces conduction velocity to slow phase 0. So that is the rapid depolarization produced from sodium channels opening. As you can see in the little graphic there, it will cause more of a gentle slant in phase 0. So all of your Class 1 antiarrhythmics, they're divided into 3 subcategories, Class 1A, 1B, and 1C, based on the degree of sodium blocking potential. And to kind of categorize their sodium blocking potential, I heard a great lecture before that said, try and think of a salty cab driver. Salt, of course, because they're blocking sodium channels, and cab driver because the Class 1C antiarrhythmics have the greatest sodium channel blocking activity, followed by A, and then B has your least potent sodium channel blocking activity. So that's just a brief overview. That's pretty much, if you're taking an exam like the NAPLEX or something, that's really all you need to know from a very overview-based perspective on the Class 1 antiarrhythmics. Just as an overview, not the individual agents, of course. So, Class 1A. First up, procainamide. So that is one of the recommended agents for rapid AFib in Wolff-Parkinson-White syndrome. Of course, we have an arrow pointing to those delta waves. It has no AV nodal blocking activity, so it usually means it's safe for WPW. So as long as you're not messing with the AV node, it's usually safe in Wolff-Parkinson-White. It's also useful for ventricular tachycardia because it slows depolarization. It slows that conduction velocity. Therefore, it can reduce the tachyarrhythmia. So dosing-wise, there's 2 different strategies to use. One I would find a lot more useful than the other. The first one is the package insert. It's the 17 milligram per kilo load at 50 milligrams per minute, and then you run a drip at 1 to 4 milligrams per minute for maintenance. And then the second strategy, which I find more useful in the emergency department, it's a 100 milligram IV push every 5 minutes until the arrhythmia is controlled, up to a maximum of the manufacturer recommended 17 milligrams per kilo recommended loading dose, and then you still follow the maintenance drip at 1 to 4 milligrams per minute. So essentially, it's 100 milligrams every 5 minutes until they stop going into VTAC, basically, up to the manufacturer's recommended loading dose of 17 milligrams per kilo. So notable side effects to be aware of. Drug-induced lupus is the big one. If you are taking an exam and there is a question about procainamide side effects, it is going to be drug-induced lupus. I can almost guarantee it. It can also cause hypotension, rash. The rash kind of goes with the lupus stuff, and then QTC prolongation, which is kind of to be expected here. It's also quite expensive. So it's about $1 per milligram. So if you think about loading a 100 kilogram patient, that's, 1,700 milligrams. It's about $1,700 just to terminate one episode of ventricular tachycardia temporarily. So quite expensive. And at 50 milligrams per minute, $50 a minute. Take it or leave it. It's U.S. healthcare. All right, and then next up, less popular agents, at least in my experience, is quinidine and disopyramide. It's not really used anymore just because there's more effective agents. So some learning points for quinidine. It is a CYP3A4 substrate. Immediately forget that. The big one with quinidine is remembering a side effect of synchronism, which causes tinnitus and hearing loss, specifically associated with quinidine. If you need to remember it better, somebody told me just think of it as quintinism for quinidine and synchronism. That's really like the take-home learning point with quinidine. If you get that on a test, it's going to be synchronism. It is PO only, causes QT prolongation, just like most of the other antiarrhythmics in this class. And then quinidine can also be useful for Brugada syndrome in place of an implantable cardiac defibrillator. So if for some reason they can't get a defibrillator, it could be useful for Brugada syndrome, which I have a little chart on the right here about the Brugada signs and Brugada syndrome on an ECG. So learning points for disopyramide. It is also PO only, and it has anticholinergic effects, so common anticholinergic side effects, xerostomia, constipation, and urinary retention. It makes it somewhat unattractive for the elderly patients, which are the majority of people having arrhythmias. Also causes QT prolongation and is a CYP3A4 substrate. Immediately forget everything except for the anticholinergic effects. And then also it can be used for hypertrophic obstructive cardiomyopathy if they fail or, it's not improved enough on a beta blocker or verapamil. So if they're still having dyspnea or angina, you can add disopyramide. Next up, class 1B. First agent here is lidocaine. It's only used for ventricular tachyarrhythmias, so ventricular tachycardia and ventricular fibrillation. It actually shortens your QTC interval, so that's kind of why it's effective for those arrhythmias. And it's part of the ACLS protocol for a cardiac arrest involving one of those arrhythmias. So you could do a 1 to 1.5 milligram per kilogram IV push for the first dose and then repeat at a pulse check. Just cut it in half, so 0.5 to 0.75 milligrams per kilo IV push if they are still in that rhythm. And then afterwards, for a continuous infusion, the dosing is really easy to remember because it's the same as a maintenance infusion of procainamide, 1 to 4 milligrams per minute. And it's the substrate of multiple CYP enzymes. It's important to acknowledge that it's a CYP substrate, but not really a high yield question. Next up is mexiletine, also called Mexitil. It is essentially PO lidocaine. It shortens your QTC interval, works the same way. Side effects wise, you can get tremor, GI symptoms, dizziness, ataxia, and LFT elevations. Basically the same as lidocaine. Also the substrate of multiple CYP enzymes, just something to be aware of. And then in terms of usage, it's for those ventricular arrhythmias and suppression. It's also used for PVC suppression. But it can also be used for very specific musculoskeletal disorders off-label, specifically myotonic dystrophy, and then amyotrophic lateral sclerosis with muscle spasms. So it can help out with that just because of the sodium channel blocking activity. And then usually mexiletine is dosed every 8 to every 12 hours, but the maximum dose is 1,200 milligrams per day. So everyone starts and maintains at a different dose. You don't see it used too often, so not really high yield to memorize the dosing. Just know that it's dosed 2 to 3 times a day and you have a max of 1,200. Next up, class 1C. The first one here is flecainide. So it's useful for atrial and ventricular arrhythmias. You can use it for PVC suppression and then SVT and pharmacologic cardioversion and AFib. So that's kind of one of the bigger ones actually. So dosing is quite odd. Scheduled doses, you usually divide them Q12. It's usually not worth memorizing the individual starting and maintenance doses, but just know that you don't exceed 400 milligrams per day and it's divided Q12. And then also for AFib and pharmacologic cardioversion, you could use a strategy called pill in the pocket. This was it's hard to explain, but this was really hard to find information and data on when I was in school learning about this, I don't know, like 4 or 5 years ago. Now, if you just look up pill in the pocket, AFib, you could find a multitude of different guidelines on this. So if you're doing the pill in the pocket strategy, essentially these are people that don't tolerate AFib. They've had a successful pharmacologic cardioversion in the past, and whenever they feel themselves go into an episode of AFib, they could just take a dose of flecainide and cardiovert themselves out of it. Of course, they have to have, appropriate thromboembolism prophylaxis, like most people in AFib. And then dosing-wise, it's 200 milligrams if they're less than 70 kilograms, 300 milligrams if they're more than 70 kilos, and you can't exceed more than 1 dose in a 24-hour period. Not really worth it to remember the dosing schemes here. You're just going to look it up on Google or UpToDate when you're in practice. So, in terms of side effects, the big one is 1-to-1 AV conduction, which is bad. So if you have someone that's in like a flutter, and let's say their heart rate is 70 and they're in 3-to-1 conduction, they're going to go to like 210 beats per minute if they go into 1-to-1 AV conduction. So that's bad. That'll be ventricular tachycardia and they could arrest on you. So that is something to be aware of. If you see that and they're on flecainide, that is a bad sign. So remember your 1-to-1 AV conduction with flecainide. That's a high yield question for this drug. And then it's also proarrhythmic because of the widened QRS, and then it causes blurry vision and dizziness, kind of like every other antiarrhythmic. And it is contraindicated in structural heart disease, That includes left ventricular dysfunction. So your people with heart failure, not a good candidate with this drug. And AFib and heart failure kind of go hand in hand. So got to be aware of that. And then it is contraindicated if you're using it for PVC suppression. And they had a myocardial infarction more than 6 days ago, but less than 2 years ago. So essentially, the guidelines say if they've had an MI before and you're using it for PVC suppression, don't. There's an increased risk of mortality. I think that's based on the CAST study, C-A-S-T, if you want to look into that. And then it's also a major CYP2D6 substrate. So, yeah. Next up is propafenone, also known as Rhythmol. It's used for atrial and ventricular arrhythmias again. Useful for PVC suppression, SVT, and pharmacologic cardioversion for AFib, just like flecainide. So dosing schemes, you have IR tablets and ER capsules. IR is Q8, ER is Q12. And then scheduled dosing, you usually max out at about 900 milligrams per day. It's actually quite odd depending on, which sort of scheme you want to go with. And then you can also use this for a pill-in-the-pocket strategy for AFib. Again, make sure that they are appropriately anticoagulated, and they have to have tolerated a pharmacologic cardioversion in the past, so you'll know it'll be successful. Dosing for that's 450 milligrams if they're less than 70 kilos, 600 milligrams if they're greater than 70 kilos. Immediately forget that and renew your up-to-date subscription. And just because you're cardioverting them, don't use the ER capsules. That is the IR tablet only, because you want it to work quickly. And, you want to reach that peak that's actually going to pharmacologically cardiovert them. So, side effects-wise, nausea, vomiting, it's proarrhythmic because of its QRS prolongation. And then the biggest one, if you're going to get a question about side effects on propafenone, is actually an unusual, I think this one's like a metallic taste, so it's an unusual taste. And then just like flecainide, it is a major substrate of CYP2D6. This one also is a substrate of CYP3A4. And then it has the same contraindications, so structural heart disease with specifically LV dysfunction. And then if you're using it for PVC suppression, just history of MI is going to rule it out for you. All right, well, that is all of the pertinent class 1 antiarrhythmics broken down for you, at least from what I've seen in practice and experienced on my exams and tests, leading up to this point. So I want to thank you a lot for watching. Again, my name is Robert Lasko. I'm the founder of MedMinded Consulting. Feel free to email any questions to that email address or comment your questions and feedback below. Looking forward to seeing you for the next one.